possible. If you've got any other questions, you can put them in the chat, and Nat will field them. And yeah, that would be great. So any questions? There are no silly questions. I'll try and do my best to answer as many questions as I can. At the end, it'd be really useful if we get some feedback on the teaching session. So without feedback, we can't improve. And on completion of the feedback, that you will get a certificate, just to prove that you attended the lecture, and that can be used for your portfolio if you like. And as I said, this will be recorded and it will be put up on our YouTube channel. So yeah, check us out. If you've got any other questions after the lecture, we've got a contact email address, medicine.d.essentials@gmail.com. And this is the first of a series of teachers. So please, if you like this, come sign up for future talks. They're all free. We'd be very grateful if you could, come back and say hi. It would be very, very useful for us. I just want to make sure that we are recording. Do you know if we're recording that?
Yes, we are recording, and I've just looked at the comments. There's a huge mix of people, which is really, really great. Lots of medical students. We've got some paramedics, some nurse practitioners as well.
Amazing. Thank you guys for coming. Hopefully you'll find this useful. So the aim of this talk really is to give you a broad overview of OSCEs, sort of the objective structured clinical examinations that medical students and nursing students and physicians associate students, for example, and paramedics that are all subject to. And this will kind of build you up for a good foundation for subsequent teachers that we carry out in the coming weeks. And hopefully you've already in your head got a bit of a structure to history taking, examinations, and communication as well. So but hopefully you might pick up a few tips and tricks on this session, and it might provide a bit of a structure just to make you a bit more relaxed whenever you perform your OSCE examinations. So the objectives that we're going to do is just review the full components of a history, have a brief overview of examinations, and this sort of a stepwise process on going through a stepwise process on the different types of examinations you may come across, and then a bit of a overview on communication stations that you might come across in your finals or your OSCE examinations. As I said, we're recording. I'm putting this up on YouTube. This is the timetable. So this week it's just an overview of histories and examination, and then the following weeks we've got cardio, rest, abdo, and then the more specialist specialties. So if any of these look interesting, please do sign up and come along. Let's go. So first thing we're going to do is have a look at history, how to do a standard comprehensive history, and then go into a few details according to the presenting complaint patient. We'll go through, as I said, a stepwise process of examining the patient. We've divided it into sort of a non-emergency and emergency stations that you may or may not come across in your examinations, and then kind of an overview of the different types of communication station that you might be asked to participate in your OSCEs. So histories is our first one. As you can see, so on the left side, we have a general structure of how to carry out a basic history, and we'll just go through this step by step. I think with any OSCE or any examination, it's really important to carry out the WIPER acronym. This will get you points before even taking a history. It will show the examiner that you're thinking patient safety, and it will get you points. So the first thing that you need to do is wash your hands. Make sure that the examiner sees you wash your hands in a stepwise fashion. And because of coronavirus and COVID-19, it would be appropriate to don PPE, or at least verbalize that you would don PPE before assessing the patient. And in A&E, we usually wear goggles, a surgical mask, plastic apron, surgical gloves. So that may not be available to you at the time, but it's important to at least verbalize that you would do that. And then after that, also really important, introduce yourself, introduce your role, and gain consent. So my name's Logan, I'm your doctor today. Would it be okay if I asked you a few questions about why you came? So introduce yourself, gain explicit permission and consent. Exposing and repositioning the patient, so that would be more appropriate in examining stations. For history taking stations, as long as the patient's comfortable and doesn't look to be distressed or in pain at all. And you can confirm these by asking the patient explicitly if they're comfortable, if they're in pain. And also, just as an aside, it's important to be aware if there is another person in the room other than the patient and the examiner, to confirm their role, if they're a carer, if they're a next of kin, and their relationship to the patient, and making sure that the patient consents that they are in the station at that time. And that's just quite useful to ask. Presenting complaints. So this is probably one of the most important things that you're going to get from the patient. So I like to ask, what's actually brought you in today? From an A&E standpoint, where I normally work, sometimes patients will start talking about things that happened 5-6 years ago. It's important to steer the patient in a sort of an appropriate direction and ask them, what's actually brought you in today, or how can I help today? And making sure that you ask an open question, let them speak, and getting that presenting complaint, that's really, really important. And then delving a bit deeper, so history of presenting complaints. So you want to establish if their presenting complaint is acute, so if it's brand new to them all of a sudden, or if it's a chronic thing, if it's been going on for a long time. And then again, asking the patient exactly why they've come in. So if they've got a history of, for example, COPD and a chronic cough, if they've come in today because their cough is getting worse, then you can establish that in the history of presenting complaint. So worsening symptoms, worsening discomfort, worsening pain. This is also a really good acronym. I hope everyone's familiar with this. It's Socrates. So for pain, it's really important to use this in any history taking. So for example, with chest pain, it's for example, a patient comes in with left-sided chest pain, to refer to the site. It came on all of a sudden. The onset character is dull, sharp, twisting, turning, aching. It radiates to the left jaw, the left shoulder. Any associated symptoms, the patient feels sick. If they've got a fever, a temperature, if they've got shortness of breath. The timing, so if it's there all the time, if it's constant, if it comes and goes. Any exacerbating or relieving factors, so if exertion makes the chest pain worse, or sitting still makes the chest pain worse, breathing in, if it's pleuritic, if it's not, and then severity out of 10. So the way I ask is, if you were to score your pain out of 10, with 10 being the worst ever imaginable, and 0 being no pain at all, what would you score the pain? So that's a really useful acronym. Past medical history, again, really important. Best to ask the patient if they see their GP for anything in particular regularly, or if they've ever been in hospital before. It's getting as much information as possible to kind of formulate a diagnosis and a bit of a plan later on. And then your drug history, if the patient is on any regular tablets, any regular medication, any regular inhalers, it's quite useful to ask. If they take any over-the-counter drugs or PRN drugs as required. And then it's also really important to ask about allergies. So some patients will say they are allergic to something. You need to confirm the type of allergy that they've got, the type of reaction that they've got. Patients that feel unwell to medication is not an allergy. if somebody's got true anaphylaxis, that is an allergy. So that's really important to get that distinction. I forgot to mention about past surgical history. So it's also really important to ask about any surgery on the patient if they come in with abdominal pain, for example, if they've had any previous surgery. Also very important to ask them how recent that surgery is. Family history, also very, very important. If anything run in the family, is there a strong family history of, in the context of chest pain, heart attacks, stroke, diabetes, high cholesterol, high blood pressure? It's really important to ask about family history as well. With social history, I didn't quite appreciate the importance of this until I was practicing and had graduated, because I don't think it was emphasized enough in my medical school. But social history can be a real deal breaker. And what I mean by that is it can determine if the patient is admitted to hospital or if the patient can be discharged home. So always really important, if, for example, you've got an elderly, frail patient, it's always really important to ask, who do you live with? Are you independent? Do you have any help that comes in? And if they say, for example, they have no help that comes in, do you have any support from family, friends, next of kin, anything like that? So it's really important to establish what the home setup is. And then you can ask about things like smoking, alcohol, or any other illicit or illegal drugs. Really, in the context of chest pain, shortness of breath, smoking history is again quite pivotal. So getting a pack year history, if the patient smokes 1 or 2 a day for a couple of years, that's much less of a deal than if they've smoked 20 a day for 20 years. And again, with drinking, just establish if it's constant, regular, if they binge drink. Okay. Review of systems. So after you've done all that, I find it really useful to do a quick top to toe. As you know, there are quite a few systems, and if somebody going on from the chest pain, so somebody comes in, it can take quite a long time to go through every single system. I just personally like to ask the patient, I'm just going to ask you do a quick top to toe and ask you a few quick questions, if that's okay. If the patient consents, I'll ask, have you experienced any headache? Have you experienced any visual symptoms? Any trouble swallowing, eating, drinking? Any chest pain, shortness of breath, palpitations? Any tummy pain? Have you been peeing normally? Talk quickly about periods, and then any leg pain or arm pain. And that's it. So literally working through every single system from the top to the bottom. I find it quite useful. Ideas, concerns, and expectations. This can get you out of this can really help steer the consultation and kind of help you formulate your ideas after, throughout the history. Some patients will be experts on themselves, especially if patients with chronic conditions. For example, if somebody's got COPD and they come in short of breath and you ask them, oh, what do you think's going on? They'll say, it's just like my normal exacerbation of COPD. And that's really helpful on kind of steering your management plan. So really important to ask, what do you think's going on? Lots of times the patient will give you a really good answer. What the patient is most concerned about is, again, very important. So asking what their primary concern is to try and answer that concern and trying to meet get through that concern appropriately. And then just asking the patient, what are you hoping for? From an A&E standpoint, again, so some patients come in, they've run out of their normal meds, it's a Saturday night, they need their meds for Sunday. Doctor, I'm only hoping for some tablets for the next day or so until I see a GP on Monday. It's just really useful to kind of get what they want so you can come up with a bit of a plan and hopefully make make the right choice with that. I just wanted to touch on exploding symptoms. So we've touched on them through the chat that I've been giving. With chest pain, I will always ask what cardinal symptoms and associated symptoms. So shortness of breath, just establishing if the patient is normally short of breath, if it's worse than normal, and what the sort of normal exercise tolerance is. With chest pain, so I'll ask about palpitations, how long they've been there for, if they're intermittent, if they've ever had them before, any pre-syncope or syncope, so if they've lost consciousness or feel faint, or any heart failure symptoms, so if they are overloaded, if they've got peripheral edema, if they're short of breath, lying flat. So it's really important to Google different exploding symptoms for different presenting complaints. So I'd recommend you guys go away, have a little look at all the different presenting complaints and Google exploding symptoms. And as well as this, always think about red flag symptoms. So things that you have to kind of act on or would steer your management further. So for example, if an elderly patient came with abdominal pain, they had reflux and dyspepsia for say 6 weeks, they had weight loss, they had night sweats, and they had dark stool. So those are all sort of red flag symptoms in the context of abdominal pain. So really useful to go away and Google some red flag symptoms as well, depending on the presenting complaint. OSCE Stop is a really good website. They actually give you lots of different exploding and red flag symptoms and lots of different presenting complaints. I really recommend you going to check this, going away and checking this, and it gives you in this format. And we've mentioned some stuff already here. So dyspepsia, red flags, anemia, weight loss, anorexia, melena, dysphagia, and swallowing difficulties. So really useful to have that structure in your mind and make sure that you cover every single red flag or most of the red flags depending on what's brought the patient. Few top tips, really useful if you guys practice. If you've got your finals coming up or your OSCEs coming up, just practice. Practice makes perfect. And practice with different people and as many people as you can, because everyone has a different style, a different technique, and the more you practice, the better you guys will be. And it's really useful to have, yes, you as a patient, for example, and then you've got someone taking a history, but also to have a third party as an examiner to provide really open and honest feedback. The more open and honest you are, the better, the better you're going to be in the long run. And as I've mentioned before, start open and then get narrower and narrower in the line of questioning. That's where you'll get marks. And if you follow that structure that we've just gone through, it starts with really open questions such as what's got you in today, all the way to red flag symptoms, which are narrow, closed questions, or the top to toe, as we've already mentioned, the review system. Fine. Does anyone have any questions at the minute? Nat, are there any questions?
Yeah, so someone had a question about elaborating on why it's important to get a social history. So I just reiterated the point that if you've got a vulnerable patient that might be medically well, that doesn't necessarily mean that they're safe at home.
Exactly, yeah.
Yes. Yeah. Let's see if there's any other questions. Not just yet, no.
No. Okay, so the next part of the talk is about examinations. So hopefully that was slightly helpful in giving you a bit of a structure. And we've divided this into emergency scenarios versus non-emergency scenarios. So depending on what you're asked to do in your OSCE, you could be presented with a scenario. You're asked to see a patient that is feeling unwell, and then the examiner may or may not say something along the lines of the patient collapses in front of you. And hopefully you will all be trained in basic life support. It's really useful to have that algorithm in your head and follow the Dr. ABC that you've probably all been trained in. So let's just go through that quickly. So if someone does collapse on you, or you're asked to assess an unwell patient, ensuring outside of a clinical setting, so this is outside of a hospital, it's important to ensure that there is no danger, and if there is dangerous obstacles, to remove them, checking the response of the patient, and if the patient isn't responsive, then shouting for help, and then assessing the patient in an airway, breathing, circulation manner. And as going through this, you need to be assessing their airway, breathing, and circulation. And if there's no respiratory rate or heart rate after 10 seconds, then you commence CPR. And hopefully everyone's familiar with that and has already assessed with that in the respective universities. From assessing a patient from an airway, breathing, circulation point of view, it's also important to look, feel, and listen, and then you can measure and treat as you go. So everyone will hopefully be familiar with A, B, C, D, E. And starting with A, we always look at the patient. So if they're alert and breathing, that's always good. So having a look, if they're comfortable, if they look short of breath, if they are breathing, and then you have a listen. If they're audibly wheezy from the end of the bed, then that's concerning. Or you can listen with your stethoscope. You measure oxygen through respiratory rate and their stats, and then you treat with oxygen if you've got an airway concern or any airway adjuncts. And if there is an airway concern, it's always important to escalate and bring in as much senior help as possible. If A is okay, then you go on to B, and then having a look, making sure that the chest is equally expansive, percuss, listen, ensuring that there's enough equal air entry on both sides. By measuring and treating, so you can measure breathing by doing an ABG or chest X-ray, and then treating with high flow oxygen or different oxygen adjunct if possible, or if necessary. In terms of circulation, if the patient looks pale, if they look blue, if they look sweaty, clammy, and then you go on to assess the heart rate through palpation, so feeling for an apex beat, any beat or thrills, feeling for a pulse, commenting on the rate, rhythm, and volume of the pulse, and then listening to any heart sounds. You can do some bedside tests, doing a blood pressure, an ECG, a temperature, a urine dip if necessary, and then treat with any fluids if the blood pressure is low. In terms of disability or DEFG, so don't ever forget glucose. So disability, you comment on the patient's alertness level or do a formal GCS. GCS can sometimes be quite time consuming under pressure. So it's important to comment on their alertness scale using the altitude score. And hopefully everyone's heard of the altitude score. So if they're alert, if the patient is alert, they are A. They are alert to voice, they are B. They are alert to pain, they are P. And if they're not alert or unresponsive, then they are U. And as I mentioned, DEFG, so don't ever forget glucose, do a BM, do a temperature, comment on the pupils, and check for any rash or any fever, and then everything else. So examine the abdomen, examine the long bones, look for any bleeding, look for any signs of trauma, and look for anything else around the bed as well. So if there's an emergency scenario, assess the patient in an A, B, C, D, E manner, or sort of an ILS manner. Okay. In terms of the non-emergency examinations, there's a few general principles that we'll just quickly go over. Firstly, again, you'll get points for doing the YQQ acronym. So ensuring you wash your hands, don any appropriate PPE, introduce yourself, explicitly ask permission, gain consent, exposing and repositioning the patient if possible, or if necessary, asking if the patient is comfortable, asking them if they're in pain. It's also important to, if there's any intimate examinations, just to say, ask the patient if they would like a chaperone, or to get around that, mention that, oh, today we have a chaperone, the examiner will be our chaperone. So that's a good way to get around that issue. General principles of examination of usually the cardiovascular system, the abdominal system, abdominal examination, or the respiratory examination. You usually inspect, palpate, percuss, auscultate, and then do special tests. It's not for every single examination, but it's usually a good way to remember. It's just a good stepwise method for examining patients with in these particular examinations. And I always start with end of the bed inspection, examining the hands, examining the face, examining the chest, abdomen, and then the legs if appropriate. And then presenting your findings. This is where you'll get points. So after your examination, it's taking a minute and formulating a presentation. So presenting in the order of the examination. So in the hands, I saw X, Y, and Z. In the face, I could not see this, that. In the chest, I could hear X, Y, Z. In the abdomen, I felt X, Y, Z. In the legs, I couldn't see X, Y, Z. So important positives, pertinent negatives, and then coming up with a differential diagnosis. You may not get the actual diagnosis, but it's useful to at least formulate a list of what it potentially could be, and how you will either rule in that differential diagnosis or rule out your suspicions. And usually you would say, I would investigate this patient using performing some bedside tests in the form of a blood pressure, an ECG, a urine dip, some formal blood tests, and whatever formal blood tests you need to do for that patient, and then consider further imaging, such as an X-ray, CT scan, or any special tests that need to be discussed with the specialty, like an EEG, for example, for seizures. And then with management, I would always subcategorize your management into conservative management, medical management, surgical management, and then also comment on a biopsychosocial management approach as well. So that's how I would do it. And if you compartmentalize and present your findings with those subheadings, then that shows the examiner you're actually thinking through methodically, and you'll pick up a lot of points. So we've discussed this already. So with cardio, respiratory, and abdominal examination, you would inspect the patient from the end of the bed. And with that, I would comment if the patient looks well, if they don't look well, if they look short of breath, if they're speaking in full sentences, if they've got anything around the bed that's suspicious, so frame or stick, if they've got inhalers, if there's nebulizers at the side of the bed, anything that is semi-medical or anything at all, just have a comment on if appropriate. And then with palpation, for example, in cardiology exam, again, feel for any heaves, any thrills, feel for an apex beat. Percussion's not really applicable in cardio exam, but use the stethoscope to auscultate using the diaphragm and the bell, and then any special maneuvers to accentuate murmurs, etc. In orthopedic examinations, so the IPPA approach doesn't quite apply. You would look, feel, move the joint. So you might be asked to examine a particular joint. So, for example, the elbow joint, I would look, feel, get the patient to move it, and then you move it actively as well, and do any special tests that are needed. And again, present in the order that you examined, basically. So looking, I can see X deformity, no deformity, I can see swelling, I can see bruising. Feeling the joint, I can feel no palpable fractures or no deformities or swelling. The patient has limited or full range of movement in all planes on active and passive movements, and then comment on the special tests. And that just shows the examiner that you're thinking in a methodical approach. And as I've mentioned, investigations, bedside, formal blood tests, imaging, special tests, management would be conservative, medical, surgical, and then as well as this, bio, psycho, and social management as well. So neurological examinations, you might be asked to do a neurological examination on a specific limb. Quite useful to have this stepwise approach in your head. If they're asking you to do one limb, I would always compare with the other limb. So for example, if they're asked to do the left arm, I would also compare it with the right arm. Comment on tone, the power in every single dermatome of that limb. The sensation to light touch, at least from pinprick touch as well. Any coordination tests, looking at the reflexes, commenting on them, and checking the patient when they walk as well, and commenting on their gait. Cranial nerve exam, so I'm not sure if it applies to everyone in terms of nursing students and things, but with medical students, you may be well asked to perform a cranial nerve exam. They might ask you to do a full cranial nerve exam, or examine the lower cranial nerves or the upper cranial nerves. So it's just important again to go through each nerve in a stepwise fashion and present what you find. So any positive findings and pertinent negative findings appropriate to the patient. You might be asked to do a cerebellar exam. The acronym Danish is really useful in this type of exam. Danish stands for dysdiadochokinesia, so if the patient can rapidly alternate their hand backward and forward on a flat surface. If they can't do that, then that would be indicative of a cerebellar pathology. If they're ataxic, so if they can't walk in a straight line, or if they've got a wide-based gait. If they have nystagmus, so if they have strange eye movements on lateral movement or superior and inferior gaze. If they've got an intention tremor, any slurred speech, or if they're hypotonic or a bit floppy. So always quite useful to have that in your mind as well. And then miscellaneous surgical exams. So we'll be going through this in subsequent talks in a lot more detail. It's just to get in the mindset of what could be asked. So you may be asked to do a neurovascular examination, examine an arterial or venous system of a limb or the entire patient. You might be asked to do a genital exam, including a speculum or a colposcopy, and you might be asked to examine a stoma as well and be able to comment on the different type of stoma if it looks healthy. But again, you would look, feel, you listen to the stoma as well if appropriate. Other specialty examinations, again, we'll be going through all this in subsequent talks. You might be asked to do an obstetric examination and listen to a fetal heartbeat, a pediatric examination, or a neonatal examination in terms of like a new baby check. ENT, less common, but they may ask you to do an otoscopic examination. Ophthalmology, they may ask you to do a fundoscopy exam. They asked us to do that in my medical school in one of my exams. And then very likely you'll be asked to do a psychiatric or mental state exam on the patient as well. I've spoken a lot there. Are there any questions at all?
There's someone asking if we forget something and remember it during the exam, is it okay to just throw it in?
So yes, in a short answer, but I would just say to the examiner. So the examiner is a person just like you. So I'm sure that they've forgotten things and in their exams before. Just say I'm really sorry. I've actually forgotten to include this. I'm going to ask the patient this, or I've forgotten this in the examination. I'm going back to examine this if you've got time. There's if you run out of time, just say I would have examined this if I had more time as well. It just shows the examiner that you're thinking.
Yeah, I think also if you can make it look like you haven't forgotten and just do the bit kind of out of order, that can also look quite good. So I wouldn't worry.
Any other questions?
Just having a look. Not just yet, no.
So the final section of this talk will be about communication stations and what could potentially come up in terms of sort of breaking bad news or information gathering and that kind of thing. So the sort of overview, the three different types of stations that you can get asked is information gathering, managing a situation that is tricky or difficult, and then sort of agreeing a plan as well. So these are really key factors that will get you a lot of points in these types of stations. So difficult discussions. So for example, a patient comes into your clinic, they're frustrated that they've not had a CT scan because of the pandemic. They're angry, they've been abusive to nursing staff. You're asked to manage the situation. So it's really important to be as empathetic as possible in these scenarios. I will say, if maybe not in OSCEs, but in real life, if there is an agitated patient and it's unsafe, that your safety is priority. So if it is an unsafe scenario, to remove yourself from that situation. I don't think that that's going to happen in your OSCE exams, but it's important just to bear that in mind as well. You need to act as an information gatherer, really. Basically, set the scene, make sure that the patient is as comfortable as possible, and just ask them what is causing them so much distress, and try and get as much information as possible. Really important to acknowledge that they're angry or they're upset or they're distressed and the reason behind that. And that shows that you're empathetic to the patient, and say that, for example, this patient who had a CT scan delayed, say that, that must be really hard for you and must be really tricky. And apologizing to the patient is not an admission of guilt. So actually saying that I'm really sorry, it's been a really tricky couple of months with the pandemic. Apologizing is not an admission of guilt. So that will also get you a lot of points in these types of scenarios. And then it's formulating a bit of a plan and agreeing a plan so that this doesn't either happen again or that the issue can be resolved or to sort of prevent further issues. Don't argue with the patient. Don't blame other staff members. Patients may say that the nurse said this, the nurse said that, or another member of staff said this or that. Don't say that, I'll speak with that member of staff. It doesn't help anyone, and attributing blame will only inflame the situation. So make sure you don't attribute blame or deflect, but do escalate. If you're thinking you can't resolve this scenario, then escalate. So ask a senior colleague to help. Broach it in multidisciplinary team discussions. Ensure that if these things can be prevented, try and put a strategy in place where they can be prevented in future as well. Signpost to PAL. So in the UK, in the NHS, the patient advice and liaison service. It takes all patient complaints. So if ask the patient if they want to make a formal complaint, you will happily get them PALS contact details. That's a really nice touch as well. And if it is a dangerous incident or a serious incident, we've got these things called datexes, incident forms, and explain to the patient that, you know, I will fill out a datex form so that and escalate this appropriately, or an incident form and escalate this appropriately. And that gives a bit of confidence back to the patient that you're acting to prevent these types of things happening again. Breaking bad news. So these are really common in OSCE stations. Again, you are an information gatherer. It's really important to use, you know, gather as much information as possible before breaking any news at all. So the spikes model is really really useful in these types of scenarios. So making sure that the setting is appropriate, the patient's comfortable. For example, in a new cancer diagnosis, asking the patient if they'd like anyone to be with them during the session, and just making sure that they're as comfortable as possible, and then asking their perception. So what do they know? What would they, and invite them to ask, what would they like to know? How much information would they like to be given? Ask them explicitly how much information that you would like to be given, and then providing the information. Sometimes useful to give a warning shot. So say that I've got some unfortunate or difficult news for you, or I've got some bad news for you, then deliver the information in an open and honest and sort of direct way as possible without being unempathetic, and then acknowledge how they feel, and kind of mirror their response. That's a really good way to kind of show empathy and ensure you're coming across as sort of a human being, really. And then finally, you want to summarize what's been said, what they understand about what's been said, and kind of agree an action plan on what the next steps are. So that's quite a good way to manage those types of scenarios. But again, we will be doing a breaking bad news workshop and seminar, which will go into a bit more detail and give you a few more examples. The final type of communication station will be explaining a procedure, and this can be anything from endoscopy to inhaler technique. It's quite a common station that you might be asked to explain. And again, you're just asking the patient, for example, in inhaler technique, you know, do you understand why you're using inhalers? Can you show me your technique? Get them to explain to you what they do, and then direct them appropriately through the technique to ensure that they're safe. Is that okay? These are the resources that are quite useful. OSCE Stop, which we've mentioned before, OSCE Aid as well, Almost a Doctor. So during medical school, I used that quite a lot. It's quite a good website. Geeky Medics is more known, and it's widely used. It's very good. Oxford Medical Education as well. So that concludes the talk this evening. I hope that was useful. It's a lot of chatting, and it's hopefully gives you a bit of a structure in approaching these scenarios if you get them in your OSCEs. If you've got any questions at all, please email us, provide it in the feedback, or ask away, and I'll try and answer as many questions as possible. Thank you very much for listening.
Okay. Thank you so much, Logan. That was great. I just wanted to emphasize that we do all of this for free, so we would really appreciate you guys filling out the feedback form. It's the only thing that we get back from doing these. Whatever feedback you have would be great. There were some comments in the chat about DATEXs. So I just wanted to mention and to reiterate what you've said. So a DATEX is an incident form where harm may have happened. It might not have happened. It could be a near miss situation to a patient, and you can report it to people that can investigate it. Someone's also asked about the future sessions. Where are they? Are we going to be recording these every week? So the rest of the sessions are aiming to be on Mondays, and they should all be recorded and up on YouTube. Dates may change if people's rotas get changed, but that's what we're aiming for. Yeah, I'm going to buy Logan a microphone. Logan, your microphone's a bit rubbish. We're gonna get
Sorry.
That's what someone said. It's really good to know that it's transferable to you guys. One of the paramedics has written that it's transferable to them.
Brilliant.
Really, really helpful to know. It was great. I could hear the whole thing. Just at some points, the microphone cut out for a second.
Oh, sorry.
It was fine. I could hear all of it. Any questions, anyone? Oh, great. Also transferable to nurses. What's PACR?
Pass it one.
Some written that they're doing their PACR. I'm not sure what that stands for. Physical assessment and clinical reasoning. Cool. In the context of medical school OSCEs, would we know that the station is an emergency setting before going into the bay? Yep, so for your medical school OSCEs, you've got the station posted outside before you walk in. And it will say what the situation is roughly. And if it's an emergency, it will be something like someone's collapsed, or you'll walk in and someone will be lying on the floor. If there's trauma, you've got to think about doing your CABC, which we'll get to when we do another session, but your C is looking for critical bleeding and thinking about your C-spine before doing the rest of the ABC. I don't know, Logan, if you want to add to that. So the
No.
Yeah, okay.
You've said it, so stabilizing the C-spine first and then doing your ABC.
We'll stay on the line in case there are any other questions. Someone's asked, in the examination stations, could there be patients with obvious pathologies?
Yes. Yeah. I had a MSK station with a lady who had severe rheumatoid arthritis, and she was in a wheelchair basically because of her rheumatoid. So yeah, it can sometimes be really obvious.
Yeah. What I would do is when it gets closer to your exams, I'd speak to the years above, because sometimes there are patients that come in every year with stuff that it's just good to keep an eye out for. But otherwise, just keep practicing it. You'll get most of your marks just for doing the exam correctly. And the more that you practice, the more you'll be able to concentrate on what you're actually looking for, rather than thinking about what you need to do next. Do we need to talk through the process while doing the exam? I think different people have different styles. I don't know. Logan?
I find it quite useful. I'm looking for X, Y, and Z on the hands. I don't see any evidence of this. I don't see any evidence of that. And then whenever you're presenting, you can just present a positive finding because you've already said the negative finding.
Yeah.
But everyone's different. It depends how much time you have.
I would agree. I also think about it as the examiner's got 20 of these to do. I don't know how much attention they're going to be paying. So I do it as though I'm talking to the patient. I'll say things like, I'm just going to look at your hands, And I'm just going to look at your face and in your eyes, and that makes it really obvious. SJT. SJT is in the situational. Someone's asked, could you please deliver the webinar on SJT, please? By that, do you mean situational judgment test? We have a little bit of information on the SJT on one of our previous talks. We can think about doing a webinar on the SJT at some point. It might be a while before we get to do that, though. Someone's asked, how long are the OSCE stations?
So it depends. Some stations can be between 5 and 7 minutes, or they can go up to sort of 12, 14 minutes. It all depends on your medical school. So I would ask your medical school, because they can't keep that information from you. So you need to just ask what the format of your examinations will be. And yeah, they can't keep that information from you.
Yeah, they have to tell you.
They have to tell you. That would be very unfair if they did. If again, what Nat said, speak to someone in the year above who's done the exam. Just ask them.
So someone's asked, can you explain the difference between FY1 and FY2 roles? That's a good question.
That is a very good question. So very dependent on the type of hospital that you're in, the type of jobs that you're doing, and yeah, just it's very dependent on a lot of factors. So for example, I did my F2 in a big major trauma center, and the role, there was quite a lot of expectation on you as an F2. You had to cover a lot of wards at night, etc. Because the hospital was just bigger and there were more specialties.
What so I don't know. Would say is, as an F1, you are technically provisionally registered, meaning that True. Everything you do should be supervised.
True.
In some way. But regardless of what role you're in, you've got to make sure that you feel comfortable in what you're doing, that you're not making decisions that you're not comfortable with, and that you've got appropriate senior support. But really, an F1 is just provisionally registered. They're finding their feet. An F2, you've had a year as a doctor. You should learn the ropes by now. But they should both really be supervised. I should still be supervised. Okay.
Thank you, everyone, for coming. That was first of many talks, so really helpful for us. So thank you very much.
Feedback forms.
Oh yeah, if you could fill in your feedback form, you'll get your certificate of completion.
I posted the link again. If you've got any other questions, you can also email us. I'll just type the email in.
Thanks, guys. Appreciate it. Thank you.
Oh, yeah, we'll see you next time. Thank you. Okay, I'm going to stop recording.